Hi everyone, my name is Tremley. I'm a fourth year medical student here at Nautilus in Sudbury, and today I'll be talking to you about the project that we did looking at the referral process for skin cancers in Northern Ontario and how it could have an impact on outcomes. So we have no relationships with for-profit or non-for-profit organizations, and we have no financial support to disclose. So we really wanted to do this retrospective review so that we could see what's going on with skin cancers in Northern Ontario. We want to do this because skin cancer is a very common type of skin cancer that can be cured if identified and treated early. Most studies are done with melanoma, and they assess things that have already been diagnosed rather than following patients from pre-diagnosis to treatment, and no studies have done this in non-melanoma skin cancer. So there really is a gap in literature assessing the efficacy of how skin cancer referrals are sent and whether or not this is having an effect on patients in Northern Ontario. So the purpose of our study was firstly to assess the referral process for skin cancers in Northern Ontario by identifying a typical patient journey from pre-diagnosis to treatment. Secondly, to characterize the prevalence and management of skin cancer within a city with access to a plastic surgeon, which in this case is Thunder Bay. The main interests of our study are twofold. The first is the process leading up to treatment, or the pre-surgeon assessment. And so the questions we want to answer: where are the referrals being sent from? Are they appropriate and accurate? Is the language used specific and is a suspected diagnosis included? And if the referrals are made with an appropriate level of urgency. Secondly, we want to look at the treatment process, or the post-surgeon assessment. So how many patients are receiving conservative management such as cryotherapy or punch biopsy excision? How many are requiring a two-step process, so biopsy plus later excision? How many patients are requiring more aggressive treatments such as chemo and radiation? And other questions involving the wait times and the long-term outcomes. So what we did is we did a retrospective review of patient electronic records with a suspected cancerous skin lesion presenting to a single plastic surgeon's office in Thunder Bay between October 2013 and November 2020. The patient appointments were identified in physical log books that were suspicious for a cancerous lesion, and then the medical records were then assessed to determine if they met the inclusion criteria. So referrals were included if the lesion was found to be malignant or if the lesion had already been biopsied from the referring provider. In order to accurately assess the quality of the referrals sent from members of the providers from the community, we excluded any referrals made by dermatologists since they are experts in the skin, and we didn't want this to skew the results. In terms of the results, we identified 376 referrals that were reviewed, and only 250 of them were included in our analysis. Of the 250, 214 of them were sent by family physicians, so a very large proportion of them were sent by family docs. 101 of them were sent without a specified urgency. So this could be non-urgent, semi-urgent, urgent, and then very urgent, depending on the referring provider. 156 of them were sent with a suspected diagnosis, and there was a presumed diagnostic accuracy of roughly 68%, which was confirmed by the final pathology. So once the provider was sending the referral, they would oftentimes give an idea of what they thought it was, such as a BCC, and then we compared that with how accurate they were after the final pathology was given. And to probably no one's surprise, basal cell carcinoma was the most common lesion, accounting for roughly 2/3 of the final diagnosis. And the mean wait time from referral to consultation and from consultation to surgical intervention was roughly 22 and 35 days, respectively. So in conclusion, most of the referrals were sent from family physicians, which is not surprising, and they're often reliable in recognizing these skin lesions due to their often presumed correct diagnosis. Wait times and patient outcomes were quite acceptable given the lack of access to plastic surgeons in Northern Ontario and due to the low local recurrence rates. So if they had any further evidence of disease after the fact. And for future studies, we hope that we can include other plastic surgeons and dermatologists data in Northern Ontario to investigate the incidence of skin cancer and hopefully to increase the awareness of rates and commonly performed procedures. Thank you very much for your time, and I hope you enjoyed the presentation.